So I want you to imagine a scenario. You are attempting physical intimacy, like penetrative intercourse, for the very first time.
Right, which is a huge moment.
Exactly. There's a lot of anticipation, maybe a little nervousness, but you generally have this baseline expectation of what it's going to feel like.
You expect things to work a certain way.
Yeah, but instead of that expected experience, you encounter a literal physical roadblock, like a sharp, tearing pain, or this undeniable sensation of physically, quite literally, hitting a wall.
It is an incredibly jarring experience. I mean, it instantly turns what is supposed to be a moment of connection into a complete medical mystery
Right.
because you're expecting a clear path, and instead, you're colliding with an architectural anomaly that you had no idea was even inside your body.
And that mystery is exactly what we are unpacking today. We have a really fascinating stack of sources for this deep dive.
We do. Clinical practice guidelines from women's health clinics, some highly detailed gynecological imaging studies.
And some wild pediatric case reports, too. Our mission today is to really explore the anatomy and the pure physical mechanics of a rare but profound cause of painful sex, the vaginal septum.
It is a subject that honestly rarely gets the attention it
It
deserves.
doesn't.
When medical professionals talk about painful sex, the clinical term they use is dyspareunia. But dyspareunia is this massive umbrella term.
Right, it covers a lot.
Yeah, so to understand what a septum actually does,
Yeah.
we have to break that term down. In our sources, specialists classify this pain primarily by location. First, you have superficial or entry dyspareunia.
Which is right at the opening.
Exactly.
Yeah.
Pain isolated right at the vaginal entrance. Patients often describe this as a burning sensation or severe stinging or, very specifically, like a raw paper cut.
Oh man, just hearing the phrase raw paper cut in that context makes you wince.
It really does.
It sounds like an issue with the surface tissue.
And it generally is. It usually points toward issues with the skin, localized nerve endings, or even spasms in the pelvic floor muscles right at the opening. But on the other side of the spectrum, you have deep dyspareunia.
That's the hitting a wall feeling.
Yes. This is pain experienced much higher up in the vaginal canal or deep within the pelvic cavity, and it typically happens during deep thrusting. The descriptions here are completely different.
Like an aching feeling.
Yeah, heavy aching, a bruised feeling, or as you mentioned at the start, that blunt collision pain.
Okay, let's unpack this a bit, because our focus today isn't just on any type of dyspareunia. We are zeroing in on primary dyspareunia.
That's a crucial distinction.
Yeah, the sources really emphasize this. Primary means this pain has been present since the very first attempt at penetration.
Right, it's not something that develops later.
Exactly. Not after an infection or trauma or surgery. It has always been a barrier.
Always.
And when a patient reports primary dyspareunia, whether that's the paper cut tearing feeling or that deep collision, it acts as this massive clinical clue.
It points the medical detectives away from things like hormonal shifts or recent infections and straight toward a congenital physical obstruction.
Right. If the pain has been a constant roadblock since day one, you have to look at the literal architectural blueprint of the body.
You have to look at how the reproductive tract was originally constructed.
Which means, before we can even understand how a septum blocks penetration today, we need to understand why it's there in the first place.
I have to rewind the clock.
Yeah, take a quick trip back in time to before the patient was even born.
We are talking about fetal development at approximately 6 weeks gestation.
6 weeks. Wow, that is early.
Very early. The embryo is still tiny, but the foundation for the entire female reproductive system is already being laid down.
Okay.
It starts with these two structures called the Müllerian ducts. You can sort of picture them as two parallel microscopic tubes running down the length of developing embryo.
Just two straight tubes.
Exactly. And over time, these two parallel tubes slowly migrate toward each other in the center of the pelvic cavity. They meet, and then they fuse together.
So if these two tubes are migrating and fusing, how do they eventually form all the different complex organs? Like, do they just dissolve into each other?
Well, they fuse to form a single, continuous structure that eventually differentiates.
Oh, I see.
Yeah, so the upper portions of these fused tubes become the fallopian tubes, the middle section widens to become the uterus, and the lower section forms the upper part of the vagina.
Got it.
And then this upper section grows downward to connect with another developing structure called the urogenital sinus.
Wait, urogenital sinus? I thought we just had these two ducts migrating. What is the sinus doing down there?
That is a great question. In embryology, a sinus just refers to a cavity or a channel.
Oh, okay.
The urogenital sinus is a totally separate embryonic structure that eventually separates to form the bladder and urethra in the front and the lower third of the vagina in the back.
So the upper vagina built by the Mullerian ducts basically grows down to meet the lower vagina built by the urogenital sinus.
Exactly.
Oh.
But the really critical part of this entire process is that initial fusion of the two Mullerian ducts.
Right.
When those two parallel tubes merge, the wall between them, meaning the tissue that separated the left tube from the right tube, has to break down.
It has to get out of the way.
Right. It needs to completely reabsorb into the body to create one single, hollow, unified canal.
I love a good visual for this. So it's like two separate highways merging into one giant multi-lane tunnel.
That's a perfect analogy.
The construction crew paves the new lanes, but what happens if they forget to knock down the concrete divider between them?
That is exactly what a vaginal septum is.
Really? Just a leftover wall?
Yep. It's a failure of that central tissue to fully reabsorb during fetal development. The cellular construction crew essentially leaves the site early.
Wow.
And what gets left behind is a partition, a band of fibrous, scar-like tissue sitting right there inside the vaginal canal.
And because this happens at just 6 weeks gestation, this person grows up, goes through childhood, enters puberty, totally unaware that they have this extra concrete divider sitting inside their body.
They have absolutely no idea until they try to use the tunnel.
Right. So depending on how that tissue failed to reabsorb, our sources say that divider can basically take two distinct forms.
Right.
And the first one detailed in the clinical guidelines is the longitudinal vaginal septum.
Which is the vertical divider.
Yeah. A longitudinal septum runs lengthwise vertically down the vagina. It essentially divides the vagina into a left and a right canal.
Exactly. And if we look at the bigger picture of fetal development here, because this is an error in how the Mullerian ducts fused, we often see anomalies higher up in the reproductive tract as well.
Oh, because the same tubes make the upper stuff too.
Right. So many people with a longitudinal septum also have a uterus didelphys, which is a double uterus.
A double uterus. That's incredible.
They might even have two separate cervixes or associated differences in how their kidneys developed, like missing a kidney on one side entirely.
Well, I guess that makes sense. The kidneys and the reproductive organs are developing right next to each other at the exact same time in the womb. If the blueprint glitches for one system, the neighboring system probably experienced a glitch too.
That's a very common pattern.
But let's look at the actual mechanics of the pain here. If someone has a longitudinal septum, this vertical band dividing the canal, how does that physically cause acute entry dyspareunia?
Well, think about the pure physics of penetration.
Okay.
The object attempting to enter, whether that's a finger, a tampon, or a penis, is trying to pass through a space that is literally bisected by a fibrous band.
Right. It's cut right down the middle.
So when penetration is attempted, the object hits the leading edge of this vertical tissue. This creates immense mechanical tension.
Ouch.
Yeah, the septum is being stretched, pulled laterally, and placed under severe stress. And this tissue isn't always highly elastic.
It just gives way.
When it's pushed past its mechanical limit, that tension results in actual micro-tearing or even significant tearing and bleeding of the septum itself.
So that raw paper cut feeling the clinical guidelines mentioned earlier, that's not just some colorful metaphor.
No, not at all.
It is literally the tissue of the septum tearing under the sheer tension of being forced aside.
It is a sharp, acute, localized pain right at the entry or mid-vagina. And it's caused directly by a physical structure being stretched to its absolute breaking point.
But here's the thing. There is a diagnostic clue hiding in plain sight long before someone even attempts sexual intercourse. The sources highlight tampon leakage as this classic symptom.
Yes, it is a very common presentation in adolescence.
Right. And if you're listening to this, you might be wondering why a doctor wouldn't just catch this during a routine physical, right?
You'd think so.
But think about it. If you're a teenager, you're not getting internal pelvic exams. You're using tampons, you're inserting them normally, you feel like you were doing everything right, but you are consistently bleeding through almost immediately.
Because you assume it's user error.
Exactly. You assume your body is just acting up, or maybe you're buying the wrong brand. But the reality of the mechanics here is just wild.
The vagina is divided into a left and right lane.
Right. So you put the tampon up the right lane, let's say. But the left lane is completely empty. And the menstrual blood from the left side of the uterus is just flowing right past the tampon, completely unobstructed.
It's a profound point. A simple everyday frustration, like a leaking tampon, is actually a massive medical clue pointing directly to a congenital anomaly.
And people just don't talk about it.
Because society doesn't encourage open conversations about these mechanical frustrations. A young person usually just internalizes it, assumes their body is weird, and they never mention it to a healthcare provider.
Which means they don't discover the actual issue until that first attempt at intercourse results in tearing and bleeding.
Right.
It's just heartbreaking because it is a purely mechanical issue. It's basically just plumbing.
Just plumbing.
But, okay, if a longitudinal septum is a vertical divider, what happens when the tissue runs the other way? Like, what happens when the construction crew leaves a totally different kind of blockade?
Well, then the patient is dealing with a transverse vaginal septum.
Transverse, okay.
If the longitudinal is a vertical wall, the transverse is a horizontal floor or a ceiling, depending on your perspective.
It's like a false bottom in a magician's trunk. You open the trunk, it looks like it stops halfway down, but there's actually a lot more space underneath.
That's a great way to picture it.
Except finding the false bottom in human anatomy is incredibly painful.
Very much so. A transverse septum is quite rare, actually. The sources estimate it affects roughly 1 in 72,000 to 75,000 females.
Okay, so super rare.
Yeah, it's a horizontal band of tissue that completely or partially separates the upper vagina from the lower vagina. It usually sits right at the junction between the upper third and the lower two-thirds of the vaginal canal.
The mechanics of the pain here have to be totally different from the vertical septum, though. We aren't talking about stretching and tearing at the entrance anymore.
No, this is the classic cause of deep dyspareunia.
The hitting a wall feeling.
Exactly. During deep thrusting, penetration doesn't just stretch the tissue laterally, it literally collides with it head-on.
Like blunt force trauma.
Yes. Blunt force trauma to a horizontal wall of tissue that is completely blocking the canal. The partner physically cannot penetrate any deeper, and the patient experiences a deep, aching, hitting a wall, pelvic pain.
So what does this all mean for the rest of their health? Because if there is a horizontal wall blocking the vagina, obviously sex is going to be painful. But what about menstruation? The blood comes from the uterus, which is located above that wall.
This raises a really critical physiological question, and the answer depends entirely on whether the transverse septum is classified as perforated or complete.
Okay, perforated meaning it has a tiny little hole in it, and complete meaning it's just a solid brick wall.
Right. If it's perforated, menstrual blood can escape.
Okay.
It might take much longer, though. The sources actually note that periods can drag on for many, many days because the blood is slowly draining through this tiny pinhole, almost like an hourglass.
Oh, wow, that sounds miserable.
But it does eventually escape. So these are the patients who usually discover the septum later in life due to that deep dyspareunia we just talked about.
Got it. But if it's complete, the blood has literally no exit.
None. A complete transverse septum causes massive acute medical emergencies right at the onset of puberty.
I can imagine.
The body starts menstruating, but the blood has absolutely nowhere to go. It is physically trapped. Month after month, the blood backs up.
Oh, no.
It fills the upper vagina, stretching the tissue, and then it fills the uterus. This creates a severe clinical condition called hematocolpos.
Yeah, the sources described hematocolpos, and the mechanics of it sound absolutely terrifying. The uterus essentially acts like a balloon, just endlessly expanding with trapped blood.
It does. It leads to an incredibly painful, palpable abdominal mass.
Wow.
The patient will present with primary amenorrhea, meaning they have reached puberty but have never had a period.
Oh.
Yet they'll report severe, worsening cyclic pelvic pain every single month.
Because their body is trying to have a period.
Yes, their body is going through the hormonal menstrual cycle. The uterine lining is shedding exactly as it should, but the material is entirely trapped behind that horizontal false bottom.
If this condition is causing a teenage girl's abdomen to literally fill with trapped blood, the ER doctors must be racing against the clock.
It's an urgency.
But how do they even know what they are looking for if the blockage is entirely internal? You have a teenager in the ER with severe abdominal pain. The medical team has to look past the usual suspects, like appendicitis, realize she hasn't had her first period, and then start looking for an invisible wall.
It's tough. Detection relies on a combination of clinical suspicion and highly specialized imaging.
Right.
Given that these septa are hidden deep inside the body, doctors really have to map the architecture before they can attempt to remove the roadblock.
There is a case report in our stack that really illustrates how completely hidden these anomalies can be. We've been talking about how these septa cause acute primary dyspareunia or severe menstrual blockages.
Right.
But there was a 15-year-old girl who had a longitudinal septum, the vertical one, and hers was partial, meaning it only ran partway down the canal.
So it wasn't completely obstructing the pathway.
No. And because it was partial, she didn't have severe menstrual blockages. She actually managed to have intercourse, perhaps with some discomfort that she internalized and ignored, and she got pregnant.
Wow.
And her pregnancy progressed completely normally. The medical team didn't discover the septum until she was actively in labor?
Wait, really? During labor?
Yes. She's fully term, having contractions. The doctors perform a routine bidigital and speculum physical exam to check her cervical dilation.
And they find it then?
Yeah, they find a vertical band of tissue dividing the vagina, sitting just a few centimeters inside the entrance. She had been walking around with this her entire life, got pregnant, and nobody knew until the baby was literally descending the birth canal.
That is wild.
Yeah.
It really highlights just how adaptable the human body can be, and how easily these anatomical variations can hide if they aren't causing a catastrophic obstruction. In her specific case, because it was a partial septum, the obstetric team was actually able to perform a septoplasty, which means surgically cutting the septum right then and there during the second stage of labor.
Oh, wow, so they just fixed it on the spot.
Yes, which allowed for a safe vaginal delivery.
That is some incredible on-the-fly medicine. But, okay, let's say a patient isn't in labor. A patient comes into a clinic complaining of that severe primary dyspareunia. How do specialists map this out in a controlled environment today?
Right, because we aren't just relying on a doctor feeling around during a physical exam anymore.
Thankfully.
Physical exams are the starting point, of course, as a simple internal exam can often detect the fibrous band. But to truly understand the internal architecture, modern medicine relies heavily on advanced imaging.
Okay, like ultrasounds.
3D ultrasound's a primary tool, yeah. But standard ultrasound has limitations in this specific area.
The sources mention a specific technique they use to overcome those limitations. I think it was called hydrosonovaginography.
Yes, it's also called sonocolpography.
Okay, much easier to say.
Yeah. Basically, it involves filling the vaginal pouch with ultrasound gel or a sterile saline solution during the scan.
But why do they need to pump fluid in there? Why not just look with the standard wand?
Because the vagina is what anatomists call a potential space. Under normal circumstances, the walls rest flat against each other.
Oh, I see.
So if you just look at a standard ultrasound, it can be incredibly difficult to differentiate a thin band of anomalous tissue when all the normal walls are collapsed together in a single mass.
That makes perfect sense.
By filling the space with gel or fluid, it acts as an acoustic contrast medium. It expands the canal, pushing the walls outward.
It inflates it.
Exactly. Suddenly that septum, whether it's a vertical band or a horizontal wall, stands out in stark relief against the dark fluid on the monitor.
Oh, wow.
It allows the clinician to measure exactly how thick the septum is, exactly where it attaches to the vaginal walls, and whether there are any tiny perforations allowing fluid through.
So it's basically like inflating a balloon inside a collapsed tent so you can finally see where the internal support poles are.
That's a really good way to think about it. And if the ultrasound needs more clarity, or if they suspect other issues, they will utilize an MRI.
Right.
An MRI provides a comprehensive, high-resolution, three-dimensional view of the entire pelvic floor and reproductive tract without using any ionizing radiation.
So they get the full picture.
Right. It confirms the exact location of the septum, and it allows the doctors to see if the patient also has that double uterus or the missing kidney that frequently accompanies these Mullerian duct anomalies.
Okay, so the diagnostic map is drawn. We know exactly where the concrete divider or the false bottom is located. How do we fix it? The overarching theme in all of these clinical guidelines is that this is a highly treatable mechanical issue, right?
It really is. The primary treatment for a symptomatic vaginal septum is surgical resection. The medical team simply removes the tissue that shouldn't be there.
Okay.
It is worth noting, though, that if a patient has a septum, but it isn't causing them any pain, no menstrual blockages, and no issues with tampons, clinical guidelines often suggest leaving it alone.
The classic if it ain't broke, don't fix it approach.
Exactly. But for those suffering from the acute entry pain, the deep collision dyspareunia, obstructed labor, or the medical emergency of hematocolpos.
The fix is surgical.
Yes. The primary goal is to unite the canal into one open functional space.
So what does that surgery actually entail? Are we talking about making major incisions on the abdomen?
Usually, no. The approach is almost always vaginal, meaning there are no external incisions on the abdomen at all.
Oh, that's great.
The surgeons utilize specialized scissors, or they frequently use hysteroscopic tools.
What's a hysteroscope?
It's a tiny camera with tiny instruments attached, inserted directly through the vagina. It provides incredible magnification and illumination.
Nice.
So the surgeon can see the exact microscopic line where the septal tissue ends and the normal vaginal wall begins.
And they just snip it out?
They essentially cut away the dividing tissue, yeah. But the most critical part of the surgery is not just cutting the tissue out, it's managing how the tissue heals afterward.
Oh, because if you just cut it, you're leaving raw edges of tissue behind. Wouldn't those raw edges just touch each other and sort of heal back into a solid wall?
Yes. That is a major complication called restenosis.
Oh, stenosis. Okay.
A body naturally wants to close a wound, and in a confined space, it can easily bridge the gap and recreate the septum with scar tissue.
Which puts them right back where they started.
Exactly. So to prevent restenosis, surgeons use highly specific techniques.
Hmm.
For a longitudinal septum, they frequently use a suturing method called a double-crest-plasty.
Yeah, I saw that in the notes. They resect the septal tissue, but then they meticulously suture the normal vaginal mucosa from the left and right walls together over the raw defect they just created.
Right, they cover the raw edges.
And one study reviewing 20 years of data showed that using this double-cross-plasty technique resulted in 0 cases of restenosis. I mean, that is a serious success rate.
It's highly effective at preventing scar bridging. Now, if the patient has a transverse septum, the horizontal one causing the deep dyspareunia, and it is relatively thin, the surgical approach shifts.
How so?
Well, instead of cutting a large chunk of tissue out and leaving a massive raw ring inside the canal, they might use a technique called an interdigitating Y-plasty.
Hold on. In interdigitating Y-plasty, if you don't cut the tissue out, how does the blockage actually go away? Are you just pushing the tissue to the side?
So they make very specific Y-shaped incisions into the horizontal tissue. By cutting these precise geometric flaps, they allow the tissue to literally unfold and expand outward into the walls of the canal.
Oh, wow.
They are utilizing the existing tissue to widen the circumference of the vagina, opening the canal without leaving a large raw area that would inevitably scar and contract.
Oh, I see. It's almost like origami. You're unfolding the tissue to create space, utilizing the material that is already there rather than just hacking it away and hoping it heals well.
Exactly like origami. It requires immense surgical precision, but the functional results are completely life-changing for the patients.
I bet.
Once that structural roadblock is removed and properly healed, the mechanics of the vagina function as they were originally intended.
That's amazing.
The trapped menstrual blood can flow freely. Tampons can be used without the frustration of bypassing the target.
And the sharp tearing or blunt collision pain of primary dyspareunia is entirely resolved.
Completely resolved.
It is such an incredible journey. We are talking about a microscopic cellular error at 6 weeks gestation. Just a tiny group of embryonic cells forgets to dissolve.
And the cascade from that is huge.
Right. Decades later, that microscopic error turns a teenager's first attempt at using a tampon into a deeply frustrating mystery, or turns a person's first attempt at intimacy into a painful, terrifying physical collision.
It really does.
It causes immense emotional distress, anxiety, relationship tension, all because of a literal physical wall built before they were even born.
It strongly emphasizes why medical professionals and, honestly, society in general, need to listen to patients when they say something physically hurts.
Yes, 100%.
When a patient reports, "It feels like I am hitting a wall," it shouldn't be dismissed as generalized anxiety or a purely psychological hurdle. Sometimes they are literally hitting a wall.
Yeah, and the validation of finding out it is a purely mechanical issue, an architectural glitch that can be mapped with an MRI and definitively fixed with a Y-plasty, it must be an overwhelming relief for these patients.
Absolutely. Medical knowledge is the most valuable tool we have in these situations. When a patient understands the mechanical why behind the pain, it takes the fear and the self-blame entirely out of the equation.
We've journeyed from a 6-week embryo to the operating room today. We've unpacked the physics of vertical dividers tearing at the entrance and the blunt force trauma of horizontal false bottoms.
Been a lot of ground to cover.
It has. But as we wrap up this deep dive, there's a lingering thought that I just cannot get out of my head after reviewing all of this material.
Oh, yeah. What is that?
Well, we only find these septas because they physically get in the way, right?
Right.
We find them because they block a tampon, or they cause severe primary dyspareunia, or they trap menstrual blood and create a medical emergency.
Because they cause a problem.
Exactly. They are completely invisible from the outside. Which makes me wonder, since these structural anomalies happen during fetal development, How many subtle, non-obstructive variations of internal anatomy are people walking around with right now?
Oh, that is a fascinating perspective on human anatomy.
Right. I mean, people could have slightly different branching of their pelvic nerves, or tiny, harmless pockets of tissue, or variations in their internal musculature that they will never, ever know about,
Just because it doesn't cause a symptom.
simply because their unique internal architecture has never caused a roadblock. It makes you realize that what we consider normal anatomy is really just a loose average of a million different microscopic variations.
It is a profound reminder of our biological complexity. We are not manufactured on an assembly line with perfectly uniform parts.
No, we aren't.
We are grown organically, and that complex growth process is full of unique, invisible improvisations.
But for those times when that improvisation does get in the way, when you do hit that unexpected roadblock, it is pretty amazing to know that modern medicine has the tools to find the false bottom, remove the concrete divider, and finally clear the path.